Hey, everybody. Welcome to Basically EMS, the EMS podcast for basic EMTs. I'm Chris.
I'm Wade.
I'm Kylee.
I'm Rylee.
Rylee, how about you tell us a little bit about yourself and your experience, your EMS career experience, I guess.
Yeah, I'm an EMT IV technician licensed in Washington and Oregon. I've been doing it for about 6 years. I spent a lot of time on the ambulance, started as a firefighter, and now I'm just teaching full time.
Right on.
Dope.
Cool. So today we're going to be talking about some chest injuries. As always, we want to start off with kind of the A&P and stuff. I personally am really big on when we're talking about anything that has to do with breathing, whether trauma or medical, that really understanding the difference between respiration and ventilation is incredibly important. Because you don't know how to treat correctly if you can't recognize which one of those two it is, and it could be one or each, or it could be both. So a little bit of that real quick we'll talk about. So respiration, right, is obviously the gas exchange, right? So versus ventilation, which is the mechanical movement of air in and out. So when we're doing an assessment on a patient with a possible lung injury, chest injury, we want to make sure that we're assessing to see if it's a ventilation issue, because if it's a ventilation issue, then we need to ventilate for the patient, right? Or a respiration issue, which in that case, we just need to do some oxygen, or if it's both, that we'll need to do both. So a real basic thing you need to really understand, I think, to be able to properly manage one of these patients. Coming down the structures within the heart, within the chest. So the stuff that could be affected in a patient with chest injuries, we've got the heart, which is pretty simple. Hopefully, if you're listening to this, you know a little bit about the heart. You're hopefully that far along. The lungs, and then we've got the great vessels as well. So that's going to be the aorta and the vena cava. And I feel like I'm talking a lot. So Wade, how about you jump in for the next part?
Yeah. So kind of looking into it, right? We have the heart, lungs, great vessels. And then we also have the trachea and esophagus. That's where we kind of tie in that mediastinum, that invisible line down the middle of the chest. I kind of want to backtrack towards respiration and ventilation for a moment.
Sure.
I think a common mistake that I see made is a lot of people will think, a lot of new students will think, oh, okay, this happens in the lungs. This happens in the lungs. That's where we exchange CO2 and oxygen, without the understanding of like, oh, no, this happens everywhere. You have this all over your body. Think about
Shock.
Perfusion, right? Exactly. Like we need the three things: sugar, oxygen, waste removal. Every cell in our body needs that to survive. So if we're not providing it internally, right, like you were saying, we have a respiration problem, but then we could even tie in like VQ mismatches and things like that, and like you kind of touched on, it could be a ventilation, could be a respiration problem. There are things that we can look at from a basic provider standpoint, it might kind of guide us there, but then a lot of it's very commonsensical, like when it's like, well, it's a ventilation problem. Well, what happened? Well, they got hit in the chest. They broke a rib. Well, that hurts, right? Like putting two and two together and being able to think between the lines of is this ventilation or is this respiration is really important. And if we're talking more respiration, that's where we fall into that mediastinum problems, right? If we're hurt in the mediastinum, we're not establishing good oxygen CO2 exchange. We're not circulating it because of the heart. There's just a lot that can go wrong with chest injuries, and they can go wrong pretty quickly. Yeah.
Right on. So continuing with kind of the A&P, we have the pleura. So those are those kind of little garbage sacks that all those organs live in, essentially. And so there's two of those.
Like. Huh? That's what it kind of looks like sometimes.
Yeah, I mean, it's a good visual for it, right? And so there's the visceral pleura that's going to be towards the organs, and then the parietal pleura that's kind of the outside. And then there's some fluid in there that allows those to kind of, slide against each other smoothly.
More of a glide, less of a catch.
Yeah, exactly.
I think the concept of visceral to parietal is important also just from a anatomy standpoint, because it's visceral and parietal. Those same terms show up when we talk about the abdomen. I know we're not doing that today, but visceral, parietal. If you know visceral is organ side, parietal is body side, that's going to kind of open a lot of doors for you.
I always tell people, like, if you know, like, this sounds weird, but like visceral pain, like if you've ever felt, people describe like emotional pain as visceral pain because it's very deep. That sounds weird, but like that's how I explain it to people. It's like if you just remember like visceral, like it's another way, trick to remember
Deep
the difference.
In your body, so like the inside.
Yeah, like because that's what people be like. It was a very deep visceral pain. They're talking about deep pain, so that's one of the tricks that I use to remember it.
Yeah,
visceral versus parietal.
Yeah, nice.
Yeah. And then just working down the A&P list again, we have our bones. Obviously, that's going to be a big portion of our chest. I like to describe our bones as a suit of armor, especially when it comes to the chest, right? Like there's lots of layers: skin, muscle, bone, fascia. You can keep going, right? But end of the day, think about what kind of damage could happen. This is where knowing the structures and, okay, the ribs are damaged in this section. Well, what could be damaged underneath? Was it enough pressure to break through, right? Reading our mechanism of injury is going to be huge. And bones obviously do a great job of keeping us sturdy and protected, but they're not perfect.
Yeah, that's always one thing I really push with, students is to think, like you said, beyond. So, if you think about like the scapula, that's a huge, just flat plate of bone. If that's broken, like that was a major impact. That was a lot of force put onto that body, and what that had to be transferred, right? Like that went through that scapula to what's beneath it. So yeah, having that understanding, like you said, of kind of what's beyond and not thinking about just what you're seeing, but what the implications of that injury are beyond that if we break a bone, who cares essentially, right? Other than, pelvis or femurs, that we can bleed a lot. But if you break a rib, it sucks, but it's not going to kill you. But that injury or that force that was applied to break that rib, what happens when it goes beyond, right? So
rib fractures feel like you're going to die.
I've never had one, but I have seen enough to know. Yeah.
I broke 3 ribs in high school, and it was horrific.
Yeah.
It hurt so bad. And the healing process is like, they tell you too. They're like, you're not just out of the clear, once they rule out that you don't have like a pneumothorax or anything, because they always check that. You break ribs, you get an x-ray, they're looking for a pneumothorax, but they'll be like, just so you know, for the next 2 months, you might develop one.
Yeah.
And you're like, awesome, cool.
Yeah.
So if I feel short of breath at any point, which is all the time, now I need to be worried I'm developing a pneumothorax.
Is that normal short of breath, or is that bad short, like worse short of breath?
No, you just got to do that. No, we're okay.
Okay, cool. Yeah. So, and then all that's going to be contained in the thorax. And so by definition, the thorax is everything kind of diaphragm to the neck, right?
Right.
So all those organs, everything within there.
I like to point out too, when it comes to like the thorax, you'll hear like different verbiage, like the chest cavity, the thoracic cavity, the thorax, right? I like to remember, if you know anatomy, you know that things are going to be named kind of logically, right? Like it's our thoracic cavity because all our ribs connects to the 12 thoracic vertebrae, right? And like that's how you got to start putting pieces together and thinking it like, I like to think of it as less of a rote memorization, more of a, okay, how can I put 2 and 2 together based on the names I'm seeing? At least for like, test taking purposes and our EMT purposes, that's the kind of critical thinking you're going to have to put forth, just little things, but it makes a huge difference.
Yeah. Yeah. That goes for, a lot of the A&P can just be like rote memorization if that's all you want it to be. But if you really look deeper and like start to understand the relationships, it really will open doors for you as far as understanding stuff later. It really does build on itself.
Yeah.
And then one thing that's really important to understand when we're talking about chest injuries is kind of the mechanism of ventilation and how that all works, especially once we start to talk about open chest injuries, right? So anybody want to take that one on?
I will. This is actually my jam. I love this stuff. So a lot of people struggle with pressure gradients. And really, if you can get super into the weeds of it, but if you just think basic fluid dynamics, right? Fluids follow the path of least resistance. So in a normal ventilatory process, it's just going in through your nose and your mouth, and then it goes out. It's following this equilibrium. Like the pressure inside of your lungs are never going to be the same as the atmospheric pressure. You'll always go over or under. That's what drives the pressure gradient that motivates ventilation in a nutshell. Excuse me. But it's your diaphragm that's really doing the bulk of that. So by it contracting, it's opening up that chest cavity, which, it's fluids, right? So they're going to say, oh, the pressure is, they're not going to say anything, but you get my point. So what's going to happen is it's going to try to even out. But because it's a fluid and it never reaches really a state of equilibrium, it's always going to go over when you inhale. So the pressure inside of your lungs is going to be higher than the outside, and then it just fuels that process back out. Air goes back out to meet the gradient, and then it always goes a little over. That process drives your ventilatory process in general. But again, the diaphragm plays a big role in that. A lot of people don't realize the abdomen does too. The abdomen has to create space for the diaphragm. So when I'm teaching people about like ventilation, I always remind them like some degree of belly breathing is important, But when you consider like a chest injury, that's why a lot of chest injuries, their abdomen primarily takes over. And you don't see as much of the like intercostal muscle use and things like that because the abdomen takes over a lot for a lot of chest injuries. But the diaphragm does the bulk of the work. We hope that's always how it should be, right? But because of the diaphragm contracting and relaxing and opening up that space, we're allowed to create these pressure gradients, which drives our ventilatory process. Inhalation and exhalation, I mean, inhalation is active, right? We have to create the space, and then exhalation is passive. It just happens. That's fluids acting as fluids do in fluid dynamics. But the important part about ventilation to remember is how your respiratory muscles and the diaphragms in particular are innervated. We're talking C345, keeps the man alive, if you guys have heard that phrase before. When you can have a chest injury for sure, but you also have to consider what is, like we were talking about the mechanism of injury, right? You sustain a pretty significant mechanism of injury to your chest. You can extend that also to like spinal cord injuries as well. And then your ventilatory status can go downhill because C3, 4, 5, even further down can be impacted. And then you have not only a mechanical ventilation problem, but you have a neurological ventilation problem. So, which I don't know about you guys, but I've seen a handful of those before where the mechanism was just so significant that they had chest wall trauma, but also nerve trauma. So the two don't always go hand in hand, but they certainly can.
I'm kind of glad you brought up, I am glad you brought up the abdominal breathing because you and I, we harp on bilateral chest rise fall, bilateral chest rise fall over, and to the point that's what we burn into students' minds, but there's more to it, right? Like the abdomen, especially if you look at like kiddos, right? They're belly breathers. Right. They don't use their chest rise. So, understanding that, yes, this is maybe a chest injury, but there's signs that we can look for that are not on the chest that can kind of guide us towards our decision making.
Yeah. Yeah. So, it's important to think we talk a lot about positive pressure ventilation, and that's us pushing from the outside. And just like Kylee was talking about with those pressure gradients, that's why it's called negative pressure ventilation. So if you've heard that term and you don't understand it, that's the purpose, or that's why we talk about negative pressure ventilation, because that diaphragm movement, those intercostals create negative pressure in the chest, which pulls in the atmospheric air. So
that's really the best way to describe it. You did. You just described it in 5 seconds what I was trying to describe the whole time. So that's perfect.
Yeah. Just remember negative versus positive pressure. And there's times where negative pressure ventilation isn't working, but positive pressure ventilation will really help. And having a good understanding of that negative pressure, and just like Kylee was saying, it's kind of, I think, a path of least resistance, right? As that vacuum is created in our chest. If there's holes not in our mouth and nose, then air is going to get places it's not supposed to, which we'll come back around later when we talk about pneumos. But it's really important to understand how that works, so you can start to understand the pathophysiology of pneumothorax and all that stuff. But yeah, make sure if you're listening to this, you're a new student, that you need to have that understanding, or else the other stuff just kind of falls apart. You're not really gonna get it very well.
And not kind of to stack on that, you need to understand negative pressure, but we don't provide negative pressure. That's not something we do.
Exactly.
Understand we do positive pressure, and that's how we can make a difference. Just trying to supplement their negative pressure that's not working.
Yeah.
Just think of vacuums. That's literally what they are.
Positive pressure is a push. We push from the outside. Negative pressure is a pull from the inside, right? And we can't, I guess you could, go and pull the diaphragm down. I don't know. Maybe.
We're in a bad spot if I'm doing that.
You can fall on your back and get the wind knocked out of you and go through the temporary diaphragmatic paralysis.
Yeah, that's real fun.
That's
Can
terrible.
you cut in the grape lady falling down now?
I don't know. I'll try. Maybe. Let's see. Yeah, that's great.
That's called grunting. For those of you who are wondering about the respiratory pattern that you see, that's grunting.
Yeah, so moving down, a couple different types of injuries when we're talking about chest injuries, and those are going to be open versus closed injuries. Typically, closed injuries are going to be blunt trauma, and open injuries are usually penetrating trauma, because by definition, penetrating trauma breaks the skin, right? But you can still have an open injury if somebody's hit hard, in a car accident and takes a steering wheel to the chest hard enough that might have enough force to tear the skin and create an open injury. So it's not just a straight line of like baseball bats, closed and
I'm glad you say baseball bats, because I do, and everyone looks at me like I'm crazy, and I'm like, baseball bats are a huge home defense I've gone on a lot of calls for that.
Yeah.
I've seen a lot of people take a lot of baseball bats.
Yeah, like gang violence and stuff.
Yeah,
you might
totally.
see that's not an uncommon thing. So, but yeah, that's a pretty, I feel like pretty simple one, right? Closed versus open.
And we'll get into that, I think, as we move forward. But I think just to emphasize, like, blunt trauma can be so great, it does become open.
Yes.
Just kind of doubling down.
Yes,
I have
very
a
important.
story that's a head injury. It wasn't my call, but a guy got hit with a pole or a wrought iron bar in the face, and it split his head in half. It hit him so hard. So, I mean, it happens, right?
Like somebody hit him with it.
No, it was, this was last summer. I was talking to a guy who was working for one of the fire departments up north. And it basically was like clearing a like hay baler and the what's the word I'm looking for? Just like the pole, the metal pole he was using got stuck, and he was going back and forth to the lady who was clearing it. And so he went in and she cleared it, and it sucked the pole out of his hand and came around and bapped him right in the forehead and split him in half. Apparently that was the second call they ran on this same guy that day.
Oh, wow.
First one like he took a turn in a tractor too fast and went down a hill, and like a Final Destination stuff, like stick went through the
gonna
window, like
say.
missed his face, and they're like, you should go home, and he's like, nah. And then
Should have just
obviously
called it a day at that.
Just take the
911's
day.
taught me anything. It's that if something even remotely Final Destination like happens, like I'm going home
Yeah.
and I'm sitting on my couch and I'm only drinking water.
And I'm avoiding every log truck on the way home.
Somebody's
Yeah.
like, you want a Jolly Rancher? You're like, nope.
Grapes, not today.
No hot dogs for me.
I'm by myself. So, that's terrible.
All right, cool. So let's jump into kind of the specific cardiac or specific chest injuries. So
We can tie in open or closed with these as we go.
yeah, for sure. So there's a bunch of different ones you may see. Cardiac contusion is the first one we have down here. And so that's just kind of a bruise to the heart. It's pretty simple, pretty straightforward, right? Usually going to be blunt trauma with like a closed injury.
Steering wheels.
Yep, steering wheels.
Yeah.
Even seatbelts. A lot of people forget that the force that can be applied by a seatbelt can be catastrophic sometimes.
Yeah.
They do save lives, but I mean, they can definitely cause problems.
Yeah, definitely wear your seatbelt. But
Please wear your
there's a
seatbelt.
point where,
Yeah.
especially like there's a reason that race cars have 5-point harnesses,
Exactly.
right? Like
Yep.
you're going 180 and just one strip. That's not gonna be great. Yeah, cardiac contusions. Like you guys were saying, auto accidents. I'm not quite to the generation that was around before airbags were prevalent. But all the old school guys back in the day would always talk about like, little Dorothy, the grandma that would sit really close to the
mom
steering
does
wheel.
that.
Yeah, they were the high risk of these a lot of the time. These cardiac contusions or other stuff will get down the line too, right? But yeah, so you might see that. And if the muscle is injured and filled with blood, it's gonna affect the ability for that muscle to contract and pump. And it's going to affect possibly the amount of blood being circulated through the body. So we may see just like a standard chest pain, right? That they're hurting where they were injured. A regular pulse can happen with these as the heart's kind of pissed off and we have some issues with there.
You could even see mentation changes potentially if they're not perfusing well. So, you have a patient, you show up, looks like steering wheel's bent, hit their chest, you see the bruises, looks like a duck, you're calling it a duck, but they're not acting right mentally and there's no starring on that windshield. That's when you got to start thinking, okay, this is a heart problem. It's just not getting the blood where we need it to be.
Yeah, exactly. Yeah, it's I guess that would probably be considered like cardiogenic shock because there's an injury to the heart that's affecting its ability to pump. So.
But it's trauma, so nothing we can really do. Surgical disease, just get them to a hospital.
Yeah, just supportive care. So, BVM if we need to BVM, those kind of things, make sure we're thinking about, again, the mechanism, what else could be going on, do we need cervical precautions, all that stuff, but not a whole lot we can do for those patients.
Right. This is also one of those calls where you might need to be ready to assist ventilations as needed, right? Even if they're like loosely conscious, but they're breathing 8 times a minute, you're going to have to get good at coaching them through. Okay, as you finish your breath, I'm going to give you that puff, right? Especially if like their chest is hurting, they don't want to take that full breath. So we got to be ready kind of on that end with it.
Yeah.
I've seen a cardiac contusion that had pulmonary edema. because it's acute heart failure, right? So it was flash, which was really interesting because in the setting of trauma, you don't normally see flash pulmonary edema. He had been having a ton of health problems, anyways. I figured he had a cardiac contusion, but we were leaning more towards tamponade because we're like, with how quickly he's progressing, he was probably already in some degree of edema settling in, anyways. But that's what the doc said. He was like, oh, this might just be one of those things where it just happened really quickly because he had heart failure, so he was already not doing well. But they ruled his edema as a secondary symptom to a cardiac contusion because of acute heart failure. So if it goes on long enough, ideally, it won't because we'll catch it. But that's also something is just remembering your respiratory symptoms that can be associated with acute heart failure.
Right.
It's traumatic in nature, but you can still see things like that.
Yeah. Yeah, I mean, essentially it's the same thing, right? The heart's not pumping efficiently, and so it's going to back up somewhere.
Yep.
And heart failure is what follows that. Pulmonary contusions are going to be kind of a similar thing just with the lungs, right? So it's going to be a bruise to the lung. And we need to remember that the lung tissue needs that surface area for that gas exchange to happen. And so if there's blood starting to fill that lung tissue because of a hematoma or, like this contusion, that tissue is no longer we're not recruiting that tissue for gas exchange. And so depending on the size, it can have pretty profound effects. Patients, you'll at least probably see maybe some shortness of breath because, they'll only have 85% of their lung that is working appropriately. And so they feel short of breath. They need to breathe faster, which real quick, you mentioned the 8. I always love to point out to everybody that's, watching this that maybe is a student, National Registry standards, less than 8, more than 28 on their respiratory rate, you need to ventilate, right?
Yeah.
So
I like that.
We forget that as actual field providers because it's not realistic, honestly, of what we're going to see. But that is the National Registry stuff. So just keep that in mind if you're listening, you haven't taken your registry yet. If they're breathing less than 8 or more than 28, the answer is PVM, always for National Registry. So you might see some shortness of breath with these patients because they don't have that alveolar recruitment like they would normally as it's saturated with blood. And then that's when you might see some hemoptysis too, some of that coughing up of blood,
right?
Just because there's blood being, created in the chest from those bruises. And so those bruises or those contusions, they might be coughing that out.
Yeah.
And then same thing, the chest pain, all the symptoms you'd expect to see. Treatment wise, just again, kind of supportive care. There's not a lot that we can do for that. Maybe the BVM if needed and some oxygen. Because again, if they're only the atmosphere has about 21% oxygen, right? And if we're only having 75% of our lung tissue that can be used, if we bump that up to 40% with a nasal cannula, then we're kind of, helping that percentage out. So sometimes something like a nasal cannula can really just help with these patients that are just a little bit low on alveolar recruitment.
I think that surface area is it's a topic that we don't talk about often enough because it's a huge thing, right? Like if you think about a lung, a normal healthy lung, you want all of that lung to be working, kind of just doubling down on what Chris said, like the second you start losing portions of that lung, you start losing perfusion once again all over the body, not just in the lungs, right? So this is more than just this is a lung problem. This is a body problem now. Recruiting everything, shock is on the horizon.
And then coming down, rib or sternum fractures. I have these written down as the same. Sternum fractures are going to be much worse than rib fractures.
So gnarly.
Yeah.
They have like an associated 60% mortality rate.
Yeah.
Because and it's like we were talking about the mechanisms, excuse me, the chances of greater vessel shearing and cardiac and pulmonary contusions is elevated, but the fracture itself, because of how much force it takes, is the trauma surgeon I talked to was like, this is serious. And I was a brand new EMT, so I had no idea. I just knew that she had a deformity. Like her sternum was very deformed, and I was like, that's not good, but we'll see. And the trauma surgeon was like, this is very, very serious. And then he told me it was a 60% associated mortality rate. And I was like, oh, wow. I don't think a lot of people would think of that. That's a very, very high number.
There's some important stuff underneath the sternum, right? Like that.
Yeah.
It makes sense if I think about it.
Yeah. If you really think about it, you're like, oh, duh.
Yeah.
The heart's right behind it. Huh.
But 60% is a big number.
60% is a large number.
Yeah. So sternum fractures, again, like you guys were saying, think about what's going beyond that. Those are significant. And then rib fractures, most of the time not life-threatening, but very painful. And then you guys, I'm sure, have all been on rib fractures. They're just maybe a little short of breath just because it hurts to breathe, right? Like when we breathe in, we expand our chest, and that's painful. So you might see some higher respiratory rates just because they're breathing shallower and faster, but they're still looking for that homeostasis to stay the same.
And the risk of secondary injury with rib fractures is huge.
Yeah.
There's a guy that I knew. I'll talk more about him later when we get to a different topic. But he was basically the dad of my sister's best friend growing up. And there was one day my mom was dropping my sister off at their house, and he was a big motorcycle guy. He ripped around the corner on a Yamaha, just a little crotch rocket, and crashed, and ended up giving himself a pneumo of 3 fractured ribs. So it's one of those, there's big stuff that can happen just because it's a rib fracture. You're not out of the woods. That's where, once again, mechanism, huge.
Yeah, I mean, that's what happened to me. Like I was saying at the beginning, like I had to go get x-rays.
Right.
And I mean, I had 2 on one side, 1 on the other, but because I had broken the ribs in numerous places, I didn't meet a flail segment. But they were like, you're going to have to come get x-rays just because like when you sleep, like they were over here on like the lateral aspect. So he's like, when you sleep, you're going to be moving around a lot.
Right.
If you get any intense, like very acute, sharp pain, you need to come back. Because he was like, the chance of developing a pneumo is still there.
Yeah.
It takes ribs a long time to heal.
Yeah.
You use them all
still
the time.
Hurt.
Yeah.
They still give me problems.
And then you brought up flail segment too, which is an important thing to talk about when we're talking about rib injuries. And so flail segment is going to be 3 or more ribs that are fractured in multiple spots. And so that essentially creates a floating section of the rib cage. And so you may recognize that as, as the chest wall goes out, because that piece is not connected, it's going to come in. And so you might have that kind of paradoxal breathing
bingo.
That you're going to be seeing with those flail segments. So old guys like me, we were trained that you would create a artificial rib cage kind of a thing. I don't know if that was the
Internal
same.
splinting? Is that where you're...
No.
Okay, because I that's what I was going to bring up next.
No, when I went through EMT school, we were taught that you would take a bunch of bulky dressings and you would wrap them very tight around the patient to create an artificial rib cage, essentially, but it doesn't do anything.
That sounds scary.
It doesn't help with the sucking in part.
No, it doesn't fix anything. You can't see it anymore, so it makes you feel better.
I was going to say out of sight, out of mind.
Yeah, it doesn't do anything for the patient. So.
I love the old like sandbag treatments, how they're like, just put a 10-pound sandbag on them. It's like, once again, if I think about it, it makes sense. Until I think about it, I'm like, that doesn't make it's hard to breathe.
I was going to say the anxiety that I think would come along with that.
Yeah.
Or the anti-anxiety weighted blankets. Just saying, here we
that's
are.
a good point.
This sandbag's going to feel like a nice hug.
Yeah.
But just on the one part that hurts.
And now we're going to get into ASMR.
Crepitus ASMR.
Yeah,
That's the other podcast.
Yeah.
So this is one of those times where it's really important for us to understand that negative versus positive pressure ventilation, because this is a flail segment. If we need to, positive pressure ventilation, because it's no longer pulling in, we're pushing from the outside. It's not going to be affected if positive pressure ventilation is going to still move that rib cage like it's supposed to. So
that's why I wanted to bring up internal splinting. I've personally only met a couple of people that worked in agencies that could do that. So essentially it is, they were EMTs, so certain states allow it at the BLS level. It's going away because basically what you're doing is you're CPAPing someone. Right. So you're CPAPing them to increase the pressure inside of their lung tissue. And then essentially like you're kind of forcing the gas exchange anyways, while decreasing the effort the patient has for just mechanical ventilation. It's nice in theory, but when you consider one of the contraindications for CPAP is a pneumo, which you can very easily induce. It's like, I appreciate the thought behind it, but it's going away. If you still work in a system that does that, I've always thought it was really interesting. I wouldn't be surprised if it goes away quite a bit here in the future, just because it's too you just can't regulate it enough.
Yeah.
But it is something that you're probably going to hear about. I know some of the like old school medics got used to doing that, internal splinting, but these days it's not a primary treatment plan. TCCC doesn't recommend it at all anymore. So.
Do you guys over in Washington, Oregon, have anything special you do with rib fractures or anything like extraordinary with flail chests?
No, I would say basically you're just going to put a pillow on their side and kind of secure it to help splint it and bring them a little bit of comfort. But like we're really not. It's just getting them to the hospital.
Right. We're not going to fix it.
Treat with diesel.
Yeah, exactly.
Yeah. Yeah, it's interesting that you were talking about that because really,
It makes some sense.
It does, but using a BVM is going to do the same thing, but give us that control to make sure that we're not over pressurizing the chest cavity. So,
where do you draw the line without any kind of like internal monitoring? Like you could use things. I imagine you could use things like if you really wanted to go get crazy, like blood gases and whatnot, to actually see what your gas exchange looks like. But for us, it's just not very practical.
Yeah, let me do that real quick on the side of the road. Let's just draw blood gas.
Yeah, so treatment for that, like we said, just kind of that supportive care. Maybe this might be something to consider ALS, especially like a flail segment, because maybe we will, do some RSI, intubate that patient, and just do that positive pressure ventilation to kind of take away because you have broken ribs, you've got knife blades buried in the chest that are moving around with every breath that can cause issues. So we might want to try to limit that with maybe some positive pressure ventilation, some intubation. So that'll be, a judgment call on the medic side. But if you're a BLS provider, it might be a good idea to get a medic en route. And just if you're thinking about the overall possibility of what's going on, if you have a flail segment, again, high mechanism, there could be internal injuries that you might want a medic there for to help if anything goes south.
And then if you get stuck as a basic provider and you don't have that, remember your tools in your tool belt, right? We can use the BVM. It's going to suck. It's going to be uncomfortable, but we can keep them alive for a moment, right? For longer than I don't know how I'm phrasing this. Long enough.
Hopefully.
Right. PHTLS and TCCC both encourage light PEEP when it comes to chest injuries like that. So we're not going to be pushing the pressure like past. I want to say TCCC recommends like 5 centimeters of water or something like that. For unconscious patients, it changes a little bit, but PHTLS is pretty much the same. They say like you can give them some PEEP, but you got to be careful. Like you don't want to push it past like 5 centimeters of water. By no means like 10 and 20. There's no reason to really be going that high for us anyways, but like 10 is kind of where we draw the line, really for the most part. But those guidelines lean towards 5 as like your pretty safe spot there, even if they have a pre-existing condition. So.
Yeah, for those of you that might not know what PEEP is positive end expiratory pressure. And so it's something that your BVM probably has a little PEEP valve on it that you can dial down. And so it gives a little back pressure when the patient breathes out, essentially, which is generally really good because it will allow the alveoli to stay open. Like the one that I think I heard a long time ago that really secured the thought in my brain of how this all works is like when you're blowing up a balloon, the hardest part of a balloon is that first one to get it to pop open, and then after that it's easy, right? But that first one takes the most force, and so PEEP keeps that first breath in the balloon of the alveoli. But it does increase the pressure in the chest. And so it's something we need to kind of walk that line. And you don't, like Kylee was saying, you don't want to do 15 centimeters of PEEP on somebody with increasing like thoracic pressure already. We don't want to increase that pressure because then we start to put force on the heart, force on the great vessels. It affects preload and afterload and all sorts of stuff. So sounds like 5 is the PHTLS recommendation.
I could be off on that. It's been a little bit since I reviewed PHTLS, but it was low.
Yeah.
Like when Wade and I went to paramedic school around roughly the same time, that's what PHTLS was encouraging, was around 5.
And 5 is the basic starting spot for most things anyway.
5 is completely reasonable. Yeah.
Yeah, and you might have a protocol, so just make sure you're looking at your protocols for it. Another thing we might see is going to be traumatic asphyxia.
That's how that kid that played in Alpha Dog died. He played Chekhov.
Yeah.
In Star Trek.
Anton something, right?
Anton something. He was crushed by his Jeep against his gate. That's how he died. Was traumatic asphyxia. I didn't realize that until I was watching Alpha Dog. What a great movie, by the way. It was on some channel, and they said rest in peace, Anton, whatever. And I looked it up, and it was like a freak accident. His Jeep kicked out of gear. He was taking a garbage can down, and the Jeep pinned him. And they didn't find him for a while. So rest in peace. I mean, that's terrible, but that's
he was young.
Yeah, he was very young, and it was from traumatic asphyxia.
I had a patient like this. He didn't die, but he was a rollover accident when we showed up. Car was upside down. Fire was getting him all supported, so the car's not rolling. And the guy was on the roof of his car with his back of his head, and then his body weight was just pinching off his neck. That's also the day I watched a fire captain punch out a window, and I was like, it's kind of unnecessary, but I get why people like you guys now. Yeah.
I was going to say, you have a window punch on one of your tools.
It's their fist.
Yeah.
It was pretty
cool. Did he
cool.
literally punch him?
Yeah, he literally
so
did.
Unnecessary.
Except for then they pulled him out the windshield that wasn't there instead of the. But it was that was pretty cool. I get it, dude.
Yeah.
Yeah, we ended up getting him out, and there's more to the story on this guy, but once we got him supine and got the neck protection, everything going, he was self-ventilating and was fine.
He was just pinned?
I think he was a little bit intoxicated and a little bit young, so I think he knew he was in trouble once he started coming to.
Incarceritis?
We started having the holding the ammonia, and he's holding his nose, and it's or holding his breath, it's you're doing the things, but I'm not going to be the one to get you in trouble. Let's get you to a hospital, let them do it.
Yeah. I mean, really, any time that because the chest wall needs to expand, right? That's how this all works. That's how we breathe. As we talked about, the diaphragm goes down, the chest wall goes out. We make that cavity larger, and it pulls air from the outside. If we can't make that cavity larger, we can't pull air from the outside. So, and that can be all sorts of things, like the guy pinned with a car. The garage door coming down on someone is a common one that you hear about. Or this is what you'll see, there's all this stuff with with police officers kneeling on people. That's one of the things that we've seen, right?
That's a good point.
That you'll see traumatic asphyxia there, especially. That's why most protocols will never allow for us to transport a patient with their hands behind their back if they're handcuffed or prone, because that just opens the chest wall, so there's no more room for it to expand. And so that's what we've seen, and that's why. I know there was you've probably seen, we've worked with somebody that worked for an agency where somebody there's somebody kind of freaking out, right? On drugs or whatever. And so they put a backboard on top of them and kind of kneeled on the backboard to try to calm them down.
I didn't.
That is, I don't like that.
No. Yeah. They killed the guy. The guy died.
Gosh.
But it was, it was essentially the same thing, just more focused because the backboard was on top of them. Right. So, something for us to be aware of, not just what we see the injury patterns, but for us to think about, are we allowing that chest expansion? If not, we can cause this traumatic asphyxia. So that's why you should not be having anybody handcuffed behind their back, sitting on the gurney, sitting back. There's nowhere for their chest to go, right? So,
there's plenty of examples of people being arrested in a prone position and then going into cardiac arrest because their chest isn't expanding. And that's prior to, the big incident that everyone has in mind with this. But that it just happens. You got to think about gravity and the weight of the body, and there's so many factors that we take for granted that are very obvious if you take the 5 seconds to put it together.
This is, I hate to move into this, but it does fall in this category, which is hangings. They very much fall in this category because even though it might not be the car, getting pinned by a car or a garage door, it's still the same mechanism, but it's localized, right? So the demarcation and the petechiae that you see is limited to usually the head. But it does come up, and I hate, it's such a downer. It's such a,
Kylee.
I know, I'm sorry, but it's a good one to bring up because I remember the first time I unfortunately saw one of those, and I was a very new EMT, and the medic explained it to me because I was like, it makes sense, but he was like, it's traumatic asphyxiation. Right? That's exactly what it is. It's just not on the scale that we were talking about, which is kind of the flukes that happen, and then you run on these calls, which are very different setting completely, but that's exactly what's happening. And it's just good to recognize the symptom and the symptoms in the presentation. I guess at that point it's presentation, like the petechiae, the obvious demarcation that you get from where the crush, or kind of crush, it's almost like a crush injury.
Yeah, essentially.
Yeah. So like from where the crush injury is below that, and then like you look up from there, that's the line of demarcation. You're going to see the different coloring of the skin, all that. So it's another type that you'll run, unfortunately.
Yeah, and that petechiae is those kind of like little blood dots that you'll see like in the eyes and in the face and everything from that increased pressures. The blood, it kind of starts to back up and can't get down. And so you'll see JVD, and it'll just massively increase pressure up in the face or above that line of demarcation, and you'll see the petechiae and all that. So, pretty gnarly calls to go on. And if you get there and they're not coded, there's again not a whole lot we can do. Just supportive care there. Yeah. Stop the injury pattern if they're the knucklehead out there working on their car without jack stands and it slips off, right? Like that's a common one we see with this, and do what we can to get the car off them, get them out of it, and then just supportive care from there. So
I get so much anxiety watching my boyfriend work on his car. While he's got the car up and the jacks, and I'm like the dog, like I'm crazy about putting the dogs inside. Like even if we just take them to go to the bathroom, I'm like, oh my gosh, stay away from the car, please. Like this is like nightmare fuel.
That means you know too much.
I know. That's called trauma.
Yeah. No, it makes you funny.
I know. It's what gives me my pizzazz.
Sprinkles.
doesn't make you funny though.
That's true.
If you frame it that way.
We could do a whole episode on psychiatric.
That's true, and how bad it is for all of us.
I refuse to be evaluated on a podcast, Kylee.
I will throw myself out there.
Oh, here's some news, Wade. This last 40 minutes has all just been a farce.
Yeah.
This is really...
You're being recorded.
Dr. Phil's going to walk in right now.
Where's the intervention sign? You guys didn't even do it right.
Phil.
All right, so moving to the next one we have is going to be Commotio cordis. So this one...
Interesting.
This one got to be more well known because, and I have it written down.
Damar Hamlin,
right? So this is going to be when there is an injury directly to the heart at the exact right time within that cardiac cycle. So, we have that electrical cycle that goes exactly the same every time. What should be going exactly the same every time. And we have the refractory periods, right? And if we hit in the right time there, it can send the heart into VTAC or VFib, right? Yeah. So, and this is something that sports injuries are usually the number one. I know I've always taught before Damar Hamlin of like baseball is a common one.
Little kids with the slugger.
Yeah, maybe not the little kids, but like high school level where they're hitting it a little harder. Yeah, they'll have the pitcher will get a comebacker, right, hit him in the chest, and then they'll just drop dead essentially, just like what happened in the NFL. He took a helmet to the chest,
shoulder,
whatever it was, to the chest, and just right at that freak accident, right at that right time. Essentially, it's defibbing the person.
Yeah.
Right.
That's what I was going to say. If we just, for those who don't know what the absolute refractory period is, just before to like not get super crazy into cardiology, but your heart has your electrical conduction system. And if you know anything about electrical circuits, there are certain points where it cannot carry another current or like generate a current. It's called the absolute refractory period because it cannot do it physically. From an electrical standpoint, it can't. So what's happening is this person is in their absolute refractory period, and then they basically are given an electrical impulse by force. So, and because, you think about mechanics, right? You can create electricity by just force, like with your alternators and things like that. That's what you're doing. So like you said, you're basically defibrillating them at a point where their heart is not capable of producing another electrical current, which is why they go into VTAC or VFib. It just shocks their whole electrical conduction system as well as the muscles. So then the muscles can start misfiring and act as their own pacemaker.
It's like a precordial thump, just opposite.
Yeah.
Yeah. So, precordial thump for the BLS providers, because we don't generally teach this for BLSs.
Right. I teach it.
Typically without a medic school. And if you have somebody that just, goes into VTAC or VFib right in front of you, you can give them a nice little whack to the chest. And it's like 10 joules or something. Like just enough to maybe convert them before without having to put on the AED pads or the the cardiac monitor and all that stuff. So it's it's essentially what's happening. It's just at the exact wrong time for the patient.
Yeah, the worst case scenario. And you consider like these are huge men, you know, and they're running so fast. Like, because I had a student ask, he was like, but how much electricity can you actually generate? I'm like, obviously it's enough. If I'm running at you, it's probably going to be more like a precordial thump, right? But like you consider some of these linebackers are, you know, 300 pounds plus.
Running 640s.
Yeah, running at, you know, however, I don't know how fast these, I don't watch football.
Fast.
It's fast. They're running fast enough that, like, I mean, you could get super into the weeds and the math of it if you're into that kind of thing, but they're running so fast and then they're hitting them blunt force in the chest. That creates electrical or like just energy, you know? So it's like, no wonder. I mean, that I've watched that video. I'm sure you guys have, kind of non-consensually because it was everywhere. And I remember watching it and just being like, oh, that was a rough hit. But then you see him get up and you're like, oh, it's just another rough hit. And then you see him go backwards and you're like, oh, that was that kind of hit.
I use that video to teach all the time with this topic because it's perfect. Kind of back to baseball. I know that lacrosse is a big sport that this happened in, but baseball catchers, that's why they wear that big, heavy plastic piece in the middle of their chest. Like, I mean, the padding for obvious if you get hit in the chest, but that one in particular, that's why it's there. Yeah. You know?
Yeah. Have you guys ever, I've never been on one of these. You guys ever been on a suspected commotio cordis?
No.
We thought maybe, but this kid, he was a teenager playing, it was lacrosse actually, and we were like, oh, maybe it was commotio cordis. No, he had a congenital heart condition. So we didn't know until I got my QA back, you know, like 6 months later.
Yeah. I mean, this is like a white whale call for people.
For
like for you to be like, you know, there's a lacrosse ball, there's the guy, you know, 2 and 2, but even then
completely reasonable. But at the same time, it was like, oh, because it was the same thing, perfect timing that would have made you think commotio cordis, but it wasn't.
I was watching that football game with a couple of medics at downtown 1-7, and they all three of us same time were like commotio cordis. Like there's no way. And then you see I can go into the weeds with this one as well. But it was pretty interesting to see it live action. It was also kind of interesting to realize this is kind of a divert from the topic, but you know, the most important people are the lowest paid in that stadium in that exact moment, you know, and that it kind of brought light to what we do in a unfortunate circumstance, but in hopefully a good way.
And they ran a call right after that one. I almost guarantee it.
Oh yeah.
They were system status, and they're like, all right, time to go pick up Betty off the floor.
It's also proof that early CPR saves lives.
Absolutely. Rapid defibrillation.
And especially for that specific scenario, that's really the definitive treatment is early. They respond really well to early defib because the heart is still in great shape, right? It's not a heart that's gone through whatever, and that's not why they coded. It was just this freak accident. And so if we can get a defib and shock them real quick, they should hopefully go right back. Their brain should be good. Everything should be fine. You just have to, hopefully you're $1 million paid athlete that has medical standby 3 feet away.
Yeah, it helps being a world-class athlete for sure. Yeah. That helps.
Yeah, but if you're out there and you hear that call for baseball or lacrosse or I mean whatever, right? And you hear like somebody just collapsed after a hit, like you better have your AED in hand as you're walking up. You better have your cardiac monitor ready, like because you might need to do it as quickly as possible.
At least consideration based on call notes, you know, like I mean, if I walked up without my monitor, I'd be pretty upset. I think typically speaking, but for sure on this kind of call where you need it.
Yeah.
Well, and keep in mind too, this can happen from any blunt force trauma to the chest. It's just we're used to seeing it with athletes. So for those of you that are, you know, listening, that work in like a rural system or something like that, I worked rural medicine for a while, and we would find people, you know, unfortunately, it would be hours afterwards, you know, and because it was like way out there. And it was like, okay, like you have to consider, like, did they have shearing of the greater vessels? Was it commotio cordis? You know, because it was blunt force trauma to the chest. Who really knows? But that was something that was always on our mind, you know, like that's blunt force trauma to the chest. It's anybody's guess at this point, but never hurt to remember that for just general blunt trauma.
I think even as I've learned, you know, knowing what I know now and then looking at my past, like I had coaches and teammates that a very common thing they do is punch you in the chest. Like that's how you pump each other up. You know, you hit each other hard and the chest get moving. And it's like, maybe that wasn't a good idea in hindsight.
I would be so upset if someone did that to me.
Yeah.
I guess chicks though. right?
Yeah,
We're
probably not a great idea.
Yeah.
That's
No,
You know, a little different for us.
for the
there's a
the
lot of
men.
like
Double
amount-
standards.
The amount of grown men that would like slap children's butts in sports back in the day.
Oh, I know.
Okay.
That was a thing. No, like right.
Yeah, like good games.
Yeah. Now I'm like, oh,
You're like, you can't do that.
yeah, probably not a good idea. There's a lot of stuff that happened back in the day that maybe not the
You give them the
smartest.
patronizing pat now.
Yeah, just a little fist bump. There you go. That's all we need.
I don't like
That's all we need.
COVID too. I don't shake people's hands. I fist bump.
I mean, it's the same thing. Like, that's just sports. Like, when I was kicking on the football team, like running off, they're slapping your head in their helmet. It's like, it still hurts, guys. Like, but maybe I'm just weak. I don't know. But
Yeah, kicker. Suck it
yeah,
up.
dude.
If you want to talk about CTE, there you go.
That's a whole different. That's a
yeah,
whole
I
different
was
podcast.
gonna say that's head injuries.
So somebody already mentioned it, but laceration of the great vessels is another one to talk about. So we have very important vessels coming off of our heart that are very large. And if you can ever actually like see a picture of what the great vessels look like
They're crazy.
yeah, I think in our minds they're like, whatever. They're like garden hoses, right?
Yeah,
Like they're huge.
they're massive.
And so if you think about if there's a laceration in the great vessels, how fast somebody could bleed out. It's very fast.
I got a story on that, actually. So the same guy I was talking about crashed his motorcycle. He actually died in a moto wreck. He went to hit a triple, big jump on the motocross track, and he came up short and he caught his back tire. And he's one of the guys who always wore all the stuff. He had all the gear you could have, but he ended up kind of rolling on his chest and ended up ripping his aorta off his heart. He bled out in less than a minute.
Yeah. So I have ridden dirt bikes my whole life too, and that's one of the things. It was super important to me to wear a chest protector. I think you and I were chatting about this one time, Chris. I wear chest protectors. I mean, I'm also a woman, so my anatomy is a little different. But if the first time you rack your chest on the handlebars, you learn pretty quickly why people wear chest protectors.
Or you catch that stick across.
Yep.
Yeah.
And then usually what happens too is when you take that handlebar, it's like not only do you lose breath, but like you could fracture your sternum, like everything we've already talked about in like motocross protective gear. I mean, motorcycles, quads, you name it. That is exactly this type of situation.
Yeah. I mean, it's one of those where if they're truly damaged, like we have like signs of shock potential, you ain't going to see any signs of shock because they're been dead.
They code so quickly.
Yeah. And to the point where it's traumatic cardiac arrest, we know it's like 95%, don't quote me on that number, but 95% of all traumatic cardiac arrests don't make it. And there's a reason, right? You're trying to fix something that's physically broken, and you're pumping blood into a chest, even if you're doing all the things right.
Yeah.
You got to have the piping.
Right.
Yeah, we're not surgeons. We can't fix that stuff, and that's what these patients need. So yeah, those great vessels could be torn, and then so signs of shock we have here. And I don't know if you guys, I have seen this one, the unequal pulses.
I've heard of people seeing it. I've never personally saw it.
Yeah, it was. We don't think it was a traumatic thing. We got called for a lady in her house that I think it was like a general weakness call out.
Those are the worst.
And we got there, and of course it was one of those ones where like her house was locked. We couldn't get in. She wasn't able to come let us in. So the fire guys actually laddered a balcony, and then that was locked, but there was a window above it. And so they laddered to that window to get in. Oh. And we got there, and she just looked like, she was like white as a sheet. She just looked like a ghost. She was so white, could barely stand up. And we get her in the back of the ambulance. And this one, like, I don't know, this was a good, I mean, you guys might have heard the story before, but like a good story for me of like, what not to do, kind of cautionary tale of like, leave your ego at the door a little bit when you become a paramedic. Because it was like a 30-year medic, like fire medic that was leading the call. And we get back, and I was like a 2 or 3 year EMT, but around enough and like had been prepping for medic school that I was like, this lady's, she's in bad shape. She looks terrible. And she's like kind of in and out of it, like, and we're there, and I'm like trying to find a pulse. I'm on her right side, trying to find a pulse. I can't find a pulse, can't palpate radial. And I'm trying to listen to the blood pressure, and I just can't hear anything. But it was a while ago. It's a diesel. Diesels are going out of favor, but it was a diesel engine, right? So it's all loud.
Those diesel ambulances are the best.
So I just can't hear anything, and I'm like, Cap, I don't have anything. I can't find a pulse. I can't find a blood pressure, whatever. And then he's like over there just looking for an IV as this lady's actively dying in front of us. He's worried about getting an IV in the parking lot, right? Like in front of her house. And he's like, oh, I've got a great radial pulse over here, which now like, I'm like, well, that should have been a big key, right? Like I wasn't a new EMT. I'd been around. He knew me. He should have known I know how to find a radial pulse.
Right.
You're like, are you sure?
Yeah, I'm sure that had you like second guessing your abilities too. For
yeah,
sure.
a little bit. And I look at his partner, who's another medic. This is how it was ran in Southern California, right? And I look at him, and he's like, I could tell he was like, I believe you. We should be going, but I'm not going to tell my 30-year captain, like, hey, bro, let's go, right? So we're there for a while as he's trying to get an IV. We had to be on scene for like at least 5 minutes in the back waiting. And finally, we start going code 2 to the hospital, which was like 4 minutes away. Which another thing, if you're new to this, like definitive care is closer than you figuring just go, right? Just get to the hospital. So we get to the hospital, back in the ambulance still. They shut the engine off, right? So I'm like, let me try one more time. And I got a blood pressure on the right arm of like 56/30 or something like, I remember it was below 60 systolic. Gross. And so I tell him, and the captain's like, oh, you really had to get that blood pressure, didn't you? And I was like, yeah, I did, right? Like he was still super nonchalant. He's like, I've got my radial over here, right? We get her into the hospital. And I remember we went to like one of the non-critical hospital rooms, and the nurse walks in, literally takes one look at her and turns around and pulls out this little phone to call charge. And like, we need to go to room 1, right? Immediately recognizes how sick she was, just what she looked like. I think she died like 3 minutes after we got there. And so that's what it was. It was like an aortic dissection that she was just bleeding into her chest. And so, which is the same thing, right? The aorta is ruptured. So that was
just a medically induced.
Yeah, it was a medical. Well, we assume she could have had a fall or something that she just wasn't able to report to us. So it could have been a traumatic thing. But so one time I've seen it, and it was a really profound call as I was a young new EMT to like really like, wow. And a really big thing for me, that a tale that I always use as an FTO of like, trust your people around you and verify if you don't, right? Like if he would have reached over and be like, oh, I don't have maybe nothing would have changed, but if he would have verified like, oh, I don't have a pulse on the right side either, like he should have recognized that as a very serious symptom, and we should have gone code 3. Would she have survived? Probably not. I mean, we were at a trauma center, so maybe, but
he got that really IV though.
Verify. He didn't.
Well,
no, never got the IV.
Then he just looks like the turd here. Yeah.
Yeah, it was not.
What a loser.
It was not good. It was not good all around.
That's a bummer.
And there was no reason to sit there. Like, if you need the IV, get the IV in or out, right? Like, we were so close to a level 1 trauma, so let's just go.
EJ.
Whatever, right? Or just let the hospital fix them. Just get in there
2 minutes away. Don't just drive.
Yeah. Seriously.
You have something?
No.
Oh, you took a breath like you were going to say something.
No, I run out of air sometimes.
That happens to all of us. That was my one time that I've seen this, and I know for sure, and it was just obviously like had a major effect on me and my thoughts and my career down the line, because the poor lady, she wouldn't have survived. But
that's kind of a rarity though. Like not many people can like, oh, for sure, I know that was it. That's kind of crazy.
Yeah, that was one of those ones where like we went back after, and they're like, oh yeah, it was an aortic dissection. We looked and we saw it, and it wasn't, because we all think about the AAA, right? Where like you have the pulsating mass in the abdomen, and it wasn't that. It was the aortic arch off of the heart is where the rupture was. So
if you've never been personally victimized by an aorta doing not what it's supposed to, or not doing what it's supposed to be doing, then you know the feeling that he's talking about, where you're just like, there's nothing. You just see it going downhill, and it's a bummer. So
treatment for that, again, not a whole lot. A surgeon,
diesel,
go
thoughts and prayers,
recognition, thoughts and prayers. And I really harp on this for especially basic EMT students and just basic EMTs in general. Like, your number one tool in your toolbox is understanding signs and symptoms and recognition.
Yep.
Because if you can recognize this stuff early, you can get them where they need to go early. So knowing these things is really important so you can recognize it.
Or get that ALS en route either way.
Yeah. Or,
agreed.
Get ALS or get to the hospital, whatever is closer.
But
right?
you can make better educated choices.
Yes.
Especially when you're like where you were working. You're in Southern California, you have 3 hospitals 2 minutes from you. Which one's a trauma center?
Yeah.
Which one's the highest level trauma center? Which one's most appropriate? So
Yeah. In my situation, it was literally everything but a major burn center, right? Cardiac, stroke, level 1 trauma. I mean, it was everything, right? And it was a stone's throw from us. Like, let's just go. So, leave your ego at the door. and recognize what our deficiencies are as EMS providers, because a medic can't change anything, right?
Right.
They need a surgeon.
Right.
So get them to a surgeon. There's a reason they drive Ferraris, right? Because they can fix those and we can't. And then coming down, the big ones that people talk about, we're going to, based off of the paper, we're going to go cardiac tamponade first, because I feel like pneumos we could talk forever about.
Sure.
But
Yep.
Cardiac tamponade is going to be a blow to the chest. This was I was talking about with little Betty that used to take the steering wheel to the chest. This was what most of the time they would see this would be, front end auto accidents with people taking the steering wheel to the chest. But it's that chest injury, and the chest also has the sac that it sits in, right, the pericardium. And so if that starts to fill with blood, it kind of chokes out the heart muscle itself. And so that's going to be cardiac tamponade, right? That heart is no longer able to contract and expand because there's fluid surrounding it. And so you're going to start to see signs of shock. That's going to be like an obstructive shock by definition, cardiac tamponade. And then we're going to see Beck's triad. That's if you guys, there's two big triads, snow and trauma. Beck's is going to be one of those.
I think we talked about Cushing's and the head injury one.
Yeah, I'm sure we did. I love to talk about Cushing's. But Beck's is going to be where you're going to see hypotension. And then if you are checking heart tones, you'll have muffled heart tones because, we're physically hearing that lub-dub is going to be those valves in the heart open, close, right? That's what we're hearing. And if it's through a bunch of fluid, we're not going to be able to hear, right? So it's going to be muffled heart tones and then JVD.
Just imagine like you're underwater and you see your friend and you yell at your friend and they don't hear you, or they barely hear you. It's that same mentality.
Yeah.
I just want to reiterate too that the pericardial sac is tough.
Yeah.
It is so tough.
It's fibrous.
Yes. It's not as like your heart will essentially be strangled of oxygen long before the pericardial sac ruptures. And that's it's surgical, right? Like I don't know about you, Wade. I learned pericardiocentesis, which is an ALS treatment, but even so, like you were saying, Chris, in the field, they need a surgeon. Yeah. Like you can obviously request ALS and all that, but this is another one of those conditions where you have to get rapid recognition, rapid treatment.
Yeah, treatment-wise, there's not a whole lot we can do.
Was pericardial in your scope when you started?
It was in the flight medic scope, not the ground medic scope in California, but it's also California. I think it, like up here, I think it maybe had been removed from Idaho.
It has been. It's since been removed.
I know there was a couple supervisors who had done it before.
Yeah, because I got my medic.
Dinosaurs. They did.
I got my medic 2014, 2015, and we were trained on it. Like we trained on how to do it. But it was kind of dependent on your scope kind of a situation. And I know for California, I think it's since been removed even from the flight medic scope most places.
Because it's scary.
Well, and it makes sense from like an infection risk. Like even you can iodine, you can sterilize that skin as best you want, but you're still putting a needle under the xiphoid into the heart sac. Like an infection in there is going to ruin whoever it lands in.
Yeah. So again, because probably people listening to this don't know what pericardial centesis is. You take a very long syringe attached.
It's wild.
A
just
very
so
long
you know.
needle attached to a large syringe, and then you palpate. You go under the xiphoid process, and you essentially angle to where you think the heart is, and you go a couple centimeters, and you pull back. Go a couple centimeters, pull back, and as you're in fleshy tissue, you're not going to pull back anything. Once you hit that pericardium, you should hopefully get some blood, and so you can actually physically drain the blood that's stuck around the heart. But
Riley's like, what?
Like, that is crazy.
Yeah. Well, you know what happens if you go too far? You put them into VTAC. Oh. So
it's called a whoopsie.
Whoopsie. Well, so you're like, oh, they're in VTAC on the monitor. We should probably pull back a little. So it's very like Wild West EMS.
Yeah, it's very last ditch effort kind of a thing.
You're really just guessing at that.
It's kind of a crapshoot.
Yeah.
Yeah, you're going where you think the heart's going to be, and like I said, a couple like a centimeter, and then pull a centimeter, and hope you don't just go too far. I'd imagine the hospital. I'm sure they do like ultrasound guided or something.
They do ultrasound guided pericardiocentesis.
Yeah. So that's probably why it's been removed, and it's one of those like high acuity, low frequency skills that. Like you maybe would do it, even those the old school guys that have done it maybe like once in a 30-year career. Right. So the risk of it's so high, or doing it to the wrong person and causing issues is probably has happened before. So you just don't see it anymore.
No,
that's one skill. I'd be like, Would it be cool? Yeah. Is it necessary? No.
But I want to do it.
But I kind of want to do it.
Yeah. Yeah. Which brings us to the next one, which is the one skill in my long career I never got to do that I wish I had.
Really?
I haven't gotten
You didn't
to
get to
do it either.
decompress?
I never got to
Really?
decompress a chest,
Oh,
no.
I guess I'm the
I
queen.
missed the
right
one
now.
day of my internship. Like the first day of my internship, Ryland decompressed somebody, and I missed it. I never got a chance
You
again.
should have bailed on his wedding then.
I know.
You didn't let me.
Yeah. Too late.
No, I got a lot of really interesting medical. I was not I just didn't get a lot of trauma.
No trauma.
In 12 years, I never worked a trauma code.
Wow.
Either they were like so dead that we weren't going to work them, or they were not dead. Like there was never like freshly dead,
Right.
or if there was, it was like, well, you're
Almost.
dead and you're dead. You can survive, so we're going to work you. And sorry, guys, right? It was always that situation. So
For the
those of you
listeners,
listening-
for the listeners, we're talking about pneumothoraxes here. That's why we have the needle
Pneumothoraces.
decompression.
yeah, so we'll bring it back. A
Thoracic.
pneumothorax. So that's going to be commonly called a collapsed lung, right?
Yep.
So throwing it way back to the beginning, like I don't know, an hour ago when we were talking about negative pressure and the pressure gradients and everything. So this can happen spontaneously. Usually there's what they call a bleb on the lung tissue, and it's the patient population is typically young, tall, adult males who smoke is the number one patient population for spontaneous pneumos. Usually rail thin and like 6'4" for whatever
And that is
reason.
medical in nature. Yes, we're just for those of you at home, just remember that is predominantly medical in nature.
Yeah.
I like the word bleb. I just want to put
I
that
know,
out there.
That
it's
is
such
the
a
word
good-
too.
it is
It's
it is
right
the word.
Yeah. It is fun to say though.
It's a good
right?
one.
Bleb.
But so it can happen spontaneously where there's a little bleb, this little piece of tissue that kind of breaks and allows that exchange where it's not supposed to happen, right? But typically for pneumothorax, we introduce another opening into the chest cavity that's not the mouth and nose, right? That's not the trachea. And so as the negative pressure, the vacuum is created in the chest, the air comes through the mouth and the nose where it's supposed to, but also can come through that extra hole because of that pressure gradient, right? If the pressure, the negative pressure is higher than the atmospheric pressure, it's going to have that exchange. So, and that will start to build up that air within the chest wall. And so that's a pneumothorax. There's a simple pneumothorax where there's just a buildup, and then a tension pneumothorax, which is where there's enough a buildup of, and it can be a hemothorax as well.
Yes.
So we're going to talk about pneumothorax, but it's really interchangeable. It could be blood causing the same thing.
Could be a hemopneumothorax.
It could
was
be
gonna
both
say,
if you're a real winner.
The hemos are often associated with pulmonary contusions as well. So keep that in mind.
Yeah. But so tension pneumo is where there is so much air or blood buildup that the mediastinum or mediastinum, I think you can pronounce it either way.
Mediastinum.
Starts to shift one way or away from the affected side.
The verbiage you see often is mediastinum is deviated laterally.
Yeah.
That's the
Yes.
text verb they like to use.
And it deviates. I don't know if you guys have seen tracheal deviation before. I saw it one time, and I was brand new EMT. I had a lot of really like cool moments as a brand new EMT. It's cool. It's a relative term.
bad for somebody.
But yeah, cool, relatively speaking. And I remember I was doing my trauma assessment, and I was like looking at it, and I was kind of coming at an angle, and I was like, no matter what angle I tilt my head at, like it's still off to the side. And I was like, and I was talking to my medic. He's like, well, you seeing anything up there? Because we just split it. We split the assessment. He did lower half, I did top half, and I was like, his trachea looks a little deviated. And I said it, but like you're brand new, so you're just like, oh yeah, I just tracheal deviation.
You see his head snap.
Yeah, he literally, if you knew him, he gets this like crazy look in his eye from the side, and he looked at me, and I was like, what? And he literally like shoved me out of the way, and he was like, no, oh no, no, because we're like 40 minutes from the hospital, and he was like, oh shit, and I'm like, what is going on? And then I really think about it, and I'm like, oh yeah. Tracheal deviation implies a tension pneumothorax. I mean, I was very, very new, and so it's one of those just delays.
And that's a late sign too, right?
Very late
Super
sign.
late.
So,
Yeah. So we had like a 20, 25 minute ETA. And then he had been out there because he was actually riding a motorcycle. Massive chest trauma. But he was still talking to us, though not very easily. And we just loaded him up and took off, which was very consistent for where we were with our transport times.
Yeah.
But I remember just looking, and I look back on it so like if I could have been like the third party observer, like, you know, have an out of body experience and just seen my face, because I was like, that really looks deviated, and like nothing going on in my mind. Completely, like, blissfully unaware that was like a huge problem. And then I talked to him afterwards, and he was like, "You got to let me know that stuff, Kylee." And I was like, "I did. I thought I did a great job."
See, I tell my students all the time, like, you've been humans long enough to know what normal looks like,
Yeah.
so you'll know when you see abnormal.
Yes.
But
Say
you got to
something.
act on it. That's you can't just be like, well, that's pretty screwed up. Anyway,
Yeah. Make sure you tell people.
Yeah, well, I think it's important that we're teaching students too, like why would there be JVD or tracheal deviation? Like, not just that it could be something that you see, and if you see it, say something, but like why?
Yeah.
What's the actual
Yeah.
background on this?
can you
Like,
put
Yeah.
the underlying together?
Yeah.
Yeah, and that was a big moment for me
Because I don't think we went over that when I went in EMT school. I was like, oh, just look for it. And I'm like,
Right.
okay, but I didn't know why I was looking
Right.
for it or why it was bad.
Yeah.
So,
There's so much pressure built up. It's literally shoving your organs out of the way.
Yeah.
That's,
Casual.
Sometimes I wish there was a camera in the back of the ambulance, because there's one
Oh, I
very
know.
specifically that I could tell you guys later of like where a lady like just stopped talking to us, and me and the fire medic were like, you know, rolling down the road, like both look at the monitor, and it was like VTAC, and we just both look at each other, and in my head I hear like wah wah, because we both just looked at each other like.
you're like,
You know, and just,
"Dang
I would have
it."
loved to have seen, like, you know, a third party view of
My
our
chart
faces.
went from 10 minutes to 30 minutes.
Yeah.
Dang.
I'm a lot, because we're bad people. We're more worried about that than the person just literally
I
died in front of
know.
me.
I'm sorry. I'm sorry.
I love those head snap moments too, where it's just like, what?
JVD?
Yeah. Yeah. One thing, I was actually just talking with my class last night about this. So, because we're getting into treatments, right? So, chest seals. You have an open chest wound, you're going to cover it, right? So, the big talk these days, because where the three of us worked, we had vented chest seals. The Hyphen brand, pretty much like their main product is the vented ones. So a vented chest seal basically acts like a pop-off valve. If you're unfamiliar with that, on your BVMs, you have something called a pop-off valve that only allows so much pressure to be built up underneath of it before it allows that air to come out of that valve. Vented chest seals have all of the research behind them to support them. Non-vented chest seals, you can always use them, but the key with them is to burp them. I don't know about you guys,
I
but
heard burping's going out of favor.
so I looked that up, and burping, the primary thing that they want you to do now is use vented chest seals, because at that point you're just letting the physics of it take over. But they're saying basically if you have flutter valves are like not it anymore. If you're at home and you've heard of a flutter valve, it was essentially like people were just using gauze to cover it, which is not appropriate when you consider, you know, it's a wound with air, and gauze is not an occlusive dressing. But the idea was that you tape down 3 sides so that you could lift the flap. The problem is that people are doing them, but they're not burping them as they should. So like they're doing the right like idea. They're actually sealing it off and like helping that air escape, but they're not doing it at the intervals necessary. Because it's just, we've done it before, right? Like we've been like, oh yeah, we'll check this every 5 minutes. Do we actually check it every 5 minutes if we get busy? No.
Depends on how much of my chart I got done.
Right. Depends on if the patient can sign their HIPAA form.
Yeah.
But the thing is basically like the standard now, TCCC and PHTLS both. I know I've referenced them a lot, but like when I'm teaching, I use their guidelines a lot because
It's the trauma standards.
yeah, you know, and you consider TCCC is founded off of a lot of what the military does. They recommend pretty much exclusively vented chest seals. I haven't found anything that confirms like if they want them on both sides, you know, but the idea is you get an occlusive dressing if it has, you know, an entry and an exit point in the case of like high velocity penetrating injuries. But vented chest seals are it. They're the thing. If you don't have vented chest seals, it's fine. You'll have to check your protocols anyways. Burping is the next best thing. But you should never just be applying essentially was what they're saying, TCCC and PHTLS are saying you should never just be applying like blindly an occlusive dressing without some attempt at burping it. Because those occlusive dressings can actually worsen the incidence of a pneumothorax.
Right.
So
I think we need to kind of take a moment and talk about identification of that pneumo, right?
Oh, yeah.
There's the moments where trauma, potential chest trauma, what's the big sign that we can see that's going to guide us? It's not deep tracheal deviation, it's not JVD, because those are both late signs. It's that unilateral chest rise.
And lung sound.
And
I was going to say
sounds.
lung sounds. Yeah, are a good one.
Because we're physically hearing the air entering and exiting the lungs when we listen to lung sounds. And so if there's a period or a spot of dead space where air is instead of lung tissue, we're not going to hear any air movement there. So you want to be looking. Usually if there's a gunshot wound on the left side, you're going to be checking the left side. And to see if there's any decreased lung sounds on that side is going to be a sign of a pneumothorax as well.
Right.
And if you don't hear anything, trust yourself.
Yeah.
Yeah, I remember the first time I didn't hear anything, I was like, maybe I just need to move the bell. And then I was like, man, that's still not working. And then it light bulbed for me, and I was like, oh, that's because it's not working, no. Kylee.
Yeah.
That's because there's no air movement here. So if you don't hear anything, trust yourself.
And that's where practicing lung sounds goes a long way.
Absolutely.
So those lung sounds, and then like you're saying, the chest rise and fall, like the unilateral chest rise and fall. Because again, when we see that chest rise, it's the expansion of the lung tissue, right? And so if the lungs, if it's full of air, it's not going to really expand like it would otherwise. So we're not going to see that. So, and these are things you can find like good videos on YouTube and stuff I always recommend like trying to look at it, because just like you were saying, you know what people, even if you don't know, you know what people like, even if you don't consciously know, you know what it looks like when a person breathes. And so if you see somebody with that unequal chest rise, you're like, oh,
something's wrong.
So it's good to see it beforehand.
Yeah, it's use all the puzzle pieces, right? Like if you're having a hard time with your like justifying your lung sound, like maybe is it me or is it the chest? You can use this multiple options, right? Like Kylee said, trust yourself for sure. But like if you're really unsure, then what's your backup plan? How can we confirm this? What's plan B?
So look for that shortness of breath, obviously, because they have less alveolar retention or recruitment, and so that's going to affect it there. Is what we're going to be seeing for that. And then late signs, the Beck's triad, you might see the tracheal deviation, maybe some altered mental status because they're just in such a significant state of shock later down the line.
The hypoxia can be super profound super quickly.
Yeah, exactly. Treatment-wise, again, the normal stuff, right? And then this is where assisted ventilations can really help, because it's that negative pressure that's building more pressure, because that's why we put an occlusive dressing on. If I have a hole in my chest here, every negative pressure within my chest is going to pull air from the outside. If I put a non-porous, and that's what an occlusive dressing is, it could be a manufactured one. It could be the chip bag that's sitting up in the front that doesn't allow gas exchange through it, like fluid exchange through it. That will stop that air from coming in. It will create that chest wall again, right? So that's the purpose of doing one of those. But if we are doing positive pressure ventilation, we're going to be pushing the air into the space instead of being pulled in, and it will stop more of that exchange, right? So positive pressure ventilation can go pretty far here. And this is one of those ones for sure, as we kind of referenced earlier, get a medic, because we can do needle decompression, where we will find the affected side and we'll take a very large needle.
They're large. They're like 10 gauge.
Big old catheters. Yeah. And we will puncture that chest wall to allow that air to escape, right? And so it will kind of allow that pressure to equalize. Some places might have like finger thoracostomies or some sort of chest tubes, especially at the flight medic level, they're going to for sure be able to do chest tubes. And so, and they'll actually attach a vacuum to that tube to get that pressure differential where it's supposed to be. But, get a paramedic en route. This is something that we can do. Like I said, I never got to, which was really disappointing.
That is so crazy.
I know,
to
it's
me.
the one thing that I really wanted to do, I didn't get to do. So make sure that you're recognizing that and getting your resources there. So you ever been on any of these ones? You ever had a good that you know of?
No, it's happened in like a department I was working for while I was on shift, but I was not on the call. I was on the tender that day. So
The water tender.
yeah,
I hated working the tender.
the worst.
I just one more thing to add. If you work in a system that has paramedics and you go on a trauma code, part of the reason that, like, I mean, we talk about the causes, you know, like for the medics, it's like the H's and T's. But for those of you at home, like just to give you the idea of how serious pneumothoraces can be if we go on a trauma code, the majority of systems in the country have their medics doing bilateral needle decompression because of just how quickly and easily tension pneumothoraces kill people. So if you don't see it, you know, like if you go on a trauma call and there's any type of chest injury at all of these things are very reasonable to think about right away. But tension pneumos seem to be one of the things that I feel like I saw a lot of pneumos in general. I only saw a couple tension, but it's a very common injury pattern. Mm-hmm. Super, super common. And that's like we treat it so aggressively because needle decompression can be so beneficial. So if you see that at home, you're like, you go to work in a system we've pretty much made it like a standard almost because of how we can treat it and how much it happens.
Yeah. Any penetrating trauma to the chest, you need to have a high suspicion of a pneumothorax. And like, I mean, I was on a gunshot wound to the chest that my job, because we had a lot of medics on that call. My job, I was like one of the support medics, I was literally listening to lung sounds the entire time. That's all I did. I would listen, and it was for like a 12-minute transport. I was just continuing just so we can make sure that doesn't happen, right? Like if you have that penetrating trauma specifically to the chest, you need to be really, really watching out for that because it can happen. And then one thing I've had this question a lot, so address it here for anybody. If you are in the military and went through like a combat lifesaver course, they teach needle decompression. It is an ALS only skill for the most part in the civilian world. So I'm sure you guys have gotten that question too.
Yeah.
You're not allowed to do that, even if you've been trained.
It's a very sensitive subject.
Yeah. And I get it, right? It's a pretty straightforward thing. It's a simple skill, but we don't.
Circumstances are different.
Yeah, they need it a lot more there than we do on the civilian side. So it makes sense for them to not have their higher level providers have it kind of behind the wall, right? So
they literally teach everyone how to needle decompress. It's crazy.
I mean, you can always check your department and see if they have like an extra module for it, if that is your desire.
That's what I was going to say. Some places like in rural, you know, like Pennsylvania, you know, where they're out there, like they allow needle decompression within an optional module. But
is that ALS only, Washington, Oregon?
Yes. ALS only.
Okay. Yeah. It's definitely the norm for it to be abnormal ILS skill, but.
Yeah, I know. They just have like eye gels are, you know, a basic skill in Washington. I was just curious.
It's all weird between the states how it differs everywhere. And then you get scope of practice.
California, no RSI. I think they might have. I know for sure they took away pediatric intubation from everybody. They might have taken away intubation altogether from everybody.
It's just cardiac arrest, right, for California? Intubation wise, I think that's the last thing I saw.
I mean, anybody that will take a tube. When I was down there, if they could take a tube, they can take a tube. But that's usually just codes, right?
Yeah.
I never intubated down there because you didn't have RSI. So that was real. My first ever RSI was all by myself here after FTO. It was real fun. Anybody have anything else? Because that's kind of what we had here. Anybody have anything else to add to kind of wrap it up?
Just have a high index of suspicion and know there's more going on beneath the scenes, right? Like just read the mechanism. Where's the damage? What else could be affected? And then pay attention to your vital signs and your visual clues.
Yeah, and you know, one thing, and this will apply to like students as they go through, but real life too. Like when we reassess, like actually reassess and think like what has changed from last time, right? Because these are injuries that can progress and get worse as they go on. So maybe the lung sounds are fine. Recheck your lung sounds when you recheck your vital signs and like, oh, maybe now, well, that's definitely diminished. There's something going on, right? Like
I look at lung sounds as a vital sign.
Oh, for sure.
Honestly,
Yeah.
I know a lot of people don't, but I do.
Yes.
Especially if there's a
Why not get as
respiratory
much information as you possibly
Exactly.
can? And it's the same reason we check CMS, PMS before and after we splint. Did we make a mistake? Is there something that changed that we didn't pick up on? Just be humble enough to recognize that.
It's one thing for the knee pain to not check lung sounds multiple times, but if you have anything like this, like that should be high on
Be
your
a
list.
DVT, Chris. Turn PE in the future.
Well, P's aren't going to change lung sounds.
Well, I was saying that's why I said it's a PE in the future.
Yeah. Anything, Rylee?
No,
No.
I think it's. I feel like I learned so much just sitting here. I'm like, wow, I am back in school right now. This is crazy.
Yeah.
But I think it's hard just because, at the BLS level, they're not really teaching us a lot of the why behind what's happening. It's just like, this is how you're going to treat it, treat for shock, like always. And just we just really don't go in depth about why certain things happen.
They kind of train preemptive care.
Yeah, exactly. So I think it's really beneficial for me to just sit here and like listen because I'm like, oh wow, there
be
was a
one of
lot
our
I
new
didn't
subscribers.
know. Yeah, exactly. I subscribe. It's fine.
Cool. Right on. Well, check us out on, we'll post the video of this on YouTube. We'll be up on Spotify, Apple Podcast, everywhere your favorite podcast is found or whatever, right? All that stuff. Send comments, all that. If there's something you want to know about.
Share, and comment for more.
Smash that subscribe button. Yeah, all that stuff. But no, for real, if there's something you guys want to see, I've said, I think before here, we're just a couple of paramedics that think this stuff is fun and feel like there's a deficiency, and just like you were saying, and want to kind of fill that, but we don't know what we're doing. So, if you want to give us a little guidance and be like, hey, here's what I found was really deficient when I went through school. Here's what I'd love to learn about. Here's what, we'd love to hear that because, we want to make everybody better providers. I think that's why I'm passionate about this. There were some major deficiencies, just like you were talking about going through my schooling of when I got to the medic level. I was like, how did I not really understand shock? That's insane.
Yeah.
Right? Like I didn't really understand shock until I got to the medic level. And so if you're out here listening to this and you're like, hey, I don't understand this, like send us a message, drop us a YouTube comment, whatever. And we're happy. We've done it before, and we're happy to kind of, take guidance on what you guys want to hear about. So
If I talk about any of my shortcomings in EMT school, I'm probably going to get fired because
I was going to say, what if you are the deficiency?
Our school owner was my EMT instructor. So.
He's mine, so I'm just a product of my teachers.
Yeah.
I've gotten much better since. So
I
there's
am
also
still the
that.
deficiency, and it's your fault you let me get this far.
Yeah,
You
that
must
is
be proud.
actually what you're in my phone as, the deficiency with a capital T.
Heyo.
Ouch.
Yeah, cool. Well, thanks for listening. Thanks for watching. Whatever you're doing, and we'll catch everybody on the next one. Thanks, Rylee. Thanks, everyone.
Yeah, thank
Bye.
you. Bye.
Bye.